This presentation evolved from a $1.15 million National Institute of Health research grant awarded to advanced brain monitoring for the assessment of factors that could help dentists achieve better outcomes with oral appliance therapy. The results of this research suggest that sex, tongue scallop, and position are the new STP for OAT. In this presentation, we're first going to extract key findings from 3 new studies and then interpret the results in a manner that provides you useful tips for oral appliance therapy optimization. Finally, we're going to review our products and explain how we've designed them in a manner that they can be used to assist you in introducing STP into your practice. Now, one of the products we designed is called the Apnea Guard. The Apnea Guard adjusts at 1 millimeter increments. It's designed with 3 different sizes of vertical dimension of occlusion: low, medium, and high. It helps you identify the target protrusion with the correct VDO. And we've provided a system that allows those settings to be articulated to the custom appliance. Now, the Apnea Guard is a trial appliance, and it can be used for up to 30 nights while you're waiting for the custom appliance to be fabricated. The first study we're going to discuss is a retrospective analysis. Now, in all of these studies, we used the same 170 patients that were intolerant of CPAP. In all cases, these patients were fitted with the Apnea Guard and then underwent a 2-night home sleep apnea test. The first night was at baseline, and the second night they wore the Apnea Guard. So for this particular analysis, we were looking to identify under what conditions would we want to consider supine avoidance therapy as an alternative or for use in combination with oral appliance therapy. So for this study, we used a responder criteria where for the oral appliance to be considered effective, it required a 50% AHI reduction or a pre-treatment AHI greater than 10 and a post-treatment AHI less than 10. Now, in looking at the characteristics of these patients, one of the things that we saw was that in non-responders, they had significantly elevated non-supine AHI compared to responders. Now, we concluded from this is when the non-supine AHI elevates, you're less likely to have a successful outcome. When we look at the supine AHI in men and women, we find that men had significantly elevated supine AHI in both pre-treatment and post-treatment. And what we concluded from this is that airway length in the supine position, with men having longer airways, does impact outcomes. When we looked at the same characteristics in the non-supine AHI, we found that men again had elevated pre-treatment AHI compared to women, but post-treatment with the Apnea Guard, there were not significant differences. Thus, we concluded that with the Apnea Guard, airway length in the non-supine position does not impact outcomes. Now, this is a complicated slide, so I'm going to try and systematically walk you through it. Most of you have been taught that how to identify positional obstructive sleep apnea is by taking the supine AHI and dividing it by the non-supine AHI. And if that ratio is greater than 2, then the patient has POSA. We've introduced an alternative ratio that takes the overall AHI and divides it by the non-supine AHI. And when that ratio is greater than equal to 1.4, they have POSA. Now, this study that we published a couple years ago required that at least 20 minutes of supine and non-supine time were required to apply these ratios. And when we compared the ratios between the 2 conditions with an AHI, a DSAC criteria of 3% and 4%, we see that these ratios are highly correlated. But then when we test them to see whether or not if they identify POSA, If they were to keep the patient off the back, that would result in a 30% reduction in the overall AHI. We find that the supine divided by non-supine AHI results in 11% of the cases being falsely identified as being POSA, in that they would not have a 30% reduction. And in 3% of the cases, they were false negatives where they would have had a 30% reduction, but they were identified as non-POSA. And when you compare that to the overall divided by non-supine ratio, you see that the differences, the number of false positives and false negatives, are markedly different. Thus, we can conclude that the overall divided by non-supine ratio is superior in characterizing POSA if the goal is to identify patients who will have an important reduction in AHI if you simply keep them off their back. Now, when we apply these ratios to look at those that responded and didn't respond to the apnea guard, we find that the responders, a significantly greater proportion of those, had POSA compared to the non-responders. Now, this was consistent with the finding we reported back in 2010 that received the Best Paper Award for the Dental Journal 000. One of the other characteristics we evaluate in our study is how many patients sleep exclusively supine. Now, this is important because if patients sleep exclusively supine, we cannot determine whether they have POSA, and we can't get an indication on what that non-supine AHI is, which we showed earlier is an indicator of oral appliance therapy success. So when we looked at these proportion of patients exclusively supine by sex, we find that over a quarter of the women and 15% of the men slept exclusively supine. Now, this is important not only for determining POSA and likelihood of successful outcomes, but we reported a couple of years ago in the Journal of Alzheimer's Disease that patients that sleep more than 2 hours a night in the supine position, the odds of developing neurodegenerative disease increased by a factor of 3.7. And when we went and looked, we found that only 12% of the patients that were in this cohort of CPAP intolerance, only 12% slept less than 2 hours a night in the supine position. So as I mentioned earlier, one of the goals of this study was to identify when it would be appropriate to consider supine avoidance as an alternative to oral appliance therapy. So we established a criteria when the non-supine AHI was less than 5 and the patient had pre-treatment POSA, and we looked at the CPAP intolerant patients. Now, we could only apply this analysis to those that did not sleep exclusively supine, but we found that when POSA could be computed, 20% of these CPAP intolerant patients met this criteria. Half of them had non-supine AHI less than 5, and the overall AHI was less than 5 with the apnea guard. But the cost utility was still benefiting supine avoidance because its costs, with the addition of a mattress topper and a side sleeping pillow to make them more comfortable, was still less expensive than a custom oral appliance. And in the other half of the cases where oral appliance therapy did not get the overall AHI less than 5, you can see the differences in the overall AHI reductions that would have been achieved by the two therapies. And here we see a cost utility of negative $13,000 because that takes into consideration the quality of life adjustments that are made for further reductions in the AHI as a result of supine avoidance. The last analysis we looked at was to identify when it might be appropriate to combine oral appliance therapy with supine avoidance. So we established the criteria that when the overall AHI was greater than 10 after treatment with the apnea guard and the patient has residual POSA, those would be those patients that we were interested in looking and applying combination therapy for. For those that met the criteria, 10% were responders and 21% were non-responders to the apnea guard. Here's what their overall AHIs look like for the responders and non-responders pre-treatment. Here's what the results look like after fitting of the apnea guard, and you can see that there's significant differences between the responders and non-responders. But then when we combine the apnea guard results with the non-supine AHI, we can see that we could significantly reduce the overall AHIs further in both responders and non-responders, and the non-responders now have an overall AHI that's equivalent to the responders. Study 2 was a within subject, repeated measures, case control design. We used the same patients from study 1, the 170 CPAP intolerant group that were fitted with the apnea guard and then underwent a 2-night study. The big difference between study 1 and study 2 was the study 2 protocol was applied prospectively, and it was designed for a cost containment program developed for insurers in the San Diego area. The intent was to use the apnea guard to identify those patients where it would make financial sense to treat them with an oral appliance, and to identify those who would likely not have a good outcome with an oral appliance and try and direct them back towards CPAP. So in order to reduce the likelihood of denial of care for patients for fitting of the custom appliance, we developed a rather lenient apnea guard responder criteria. We established that if the pre-treatment AHI was less than 20, the patients needed to exhibit at least a 30% reduction in order to be fitted with the custom appliance. Alternatively, if their AHI was greater than 20, we required a 40% reduction. For those that were qualified, were then fitted with the custom appliance, and as soon as it was delivered, an efficacy study was ordered. And then once all of the data were acquired, we compared the results from the apnea guard to the custom appliance. Now, this study is now published in the Journal of Dental Sleep Medicine, and they provide us permission to present the results. Let me first explain the differences in the functional settings between the two appliances. As I mentioned before, the apnea guard includes 3 trays for vertical dimension: low, medium, and high. We developed a technique that's similar to looking and obtaining a Mallampati score to look for tongue scallop. What we do is we relax the jaw and then take the tip of the tongue and set it on the lower edge of the lip and then look for scalloping. If the tongue does not have scalloping, women were fitted with a low VDO, which was 5.5 millimeters, and the men were fitted with a medium, which was 6.5 millimeters of VDO. If we saw scalloping, the women were fitted with the medium tray, and the men were fitted with the high tray that had 8 millimeters of VDO. Once the PVS material was set and the device in situ, we established the neutral bite and the maximum protrusion with the apnea guard. And we used those 2 settings with the apnea guard work table, where from the top we dropped down the neutral setting, and along the column we established the maximum protrusion, and the number that we come to is 70%, which is what we call the target setting. Now, based on the design of the apnea guard, it controlled vertical mouth opening. For the custom appliance, the women were prescribed 2.5 millimeters of VDO. It really depended on the least amount that could be fabricated into the custom appliance, and men were fitted with 5 millimeters of VDO. We used a George gauge bite fork in order to measure the distance between maximum retrusion and maximum protrusion. We set the custom appliance to 70% of that distance, and then it was further adjusted by the dentist as required. Now, we explained to the patients how to use elastics to control vertical mouth opening and when it might be necessary, but we did not mandate it. So now that we've introduced tongue scalloping as a variable, we wanted to confirm other studies that suggest that when the tongue is scalloped or large, that the non-supine AHIs increase. And we saw this condition, and we confirmed this in both men and women, that when there's tongue scalloping, there's going to be elevated non-supine AHI. Now, here are the results that compare the apnea guard to the custom appliance to baseline. You can see here in the overall AHI, here's the baseline, the custom appliance is green, and the apnea guard is brown. What's important is that you can see that the apnea guard delivered significantly reduced overall AHIs compared to the custom appliance. And we can see in the supine and non-supine positions, there were also trends that were where the apnea guard performed in a superior manner. Now, to continue in the study, we wanted to try and understand how it would be possible that a trial appliance was superior to the custom. So one of the areas that we looked at was focused on the overall AHI and trying to understand what could have contributed to those differences. And here we see, for example, that men with scalloped tongues, the apnea guard, because it was fitted with the increased VDO, provided superior outcomes to the custom appliance. Now, we're looking at 5 millimeters of VDO for the custom and 8 millimeters VDO with the apnea guard for those men with scalloped tongues. The differences between the custom appliance and the apnea guard were not significant in those males with normal sized tongues. Next, we wanted to use logistic regression to identify which variables predicted the apnea guard and the custom appliance post-treatment AHIs. For the various models that we use, we had the capability of including age, sex, neck size, body mass index, tongue scallop, pre-treatment AHI, and the VDO associated with either the apnea guard or the custom appliance. And as a reminder, the apnea guard had controlled vertical mouth opening and the custom appliance did not. Now, we developed a number of different models. One of them that we developed, we combined the results from the apnea guard and the custom appliance, but only fit the model to men, or we fit the model to women. In other models, we kept the apnea guard and the custom appliance post-treatment AHIs in separate models, but combined the men and the women together. So now going through the results. We used a number of different endpoints. The first was if the post-treatment AHI was less than 10, what predicted those results for men and women? And we can see that the same predictors, pre-treatment AHI and vertical dimension of occlusion of the custom or apnea guard appliance, were predictive for this endpoint in both men and women. Now, when we use the endpoint, a 50% or greater reduction in AHI, we can see that not only pre-treatment AHI and VDO remain for men, but now tongue scallop also contributed to the prediction of this endpoint. And for this endpoint in women, we found no variables that could predict this endpoint. Our final outcome measure was a AHI greater than or equal to 50% and the AHI less than 10. And this surprised us in that now we see a divergence between men and women, where VDO and tongue scallop predicted this endpoint in men, but in women, it was a pre-treatment AHI, and now BMI for the first time became predictive. So we start to see much greater differences between men and women when we're looking at this, the most extreme endpoint, that may explain some of the other results that we've seen in other studies. Now, the last models we looked at, we wanted to say what variables would predict the apnea guard post-treatment AHI. And here we can see, here are the three endpoints, and we can see that pre-treatment AHI continued to be predictive. But now when we combine the men and the women, where we're controlling vertical mouth opening and setting the vertical dimension of occlusion to tongue scallop by gender, we see that BMI becomes a significant predictor of this endpoint. And VDO is significant when a 50% reduction is required, but not for the AHI being less than 10. And we believe this is due to the fact that the vertical dimension of occlusion is not going to help with the lowering the AHI below 10, because this is more likely attributed to those males and females that have elevated non-supine AHI that the apnea guard simply can't help lower more. Now, when we look at the custom appliance on what predicted their post-treatment AHIs when we combine the men and women, we see that the only variable that's predictive is the pre-treatment AHI. And this has been something that's been repeated over and over and over again, is that oral appliance therapy is best for patients with mild and moderate sleep apnea. And part of it may be due to how we are fitting and fabricating those custom appliances. Now, our third study is a within subject repeated measures case control design. These results have not been published. It's an ongoing study. So these are preliminary findings. And the hypothesis for this study was based on the premise that if the apnea guard functional settings, the VDO, controlled VMO, and the protrusion to the target setting really contributed to the differences that we saw with the custom oral appliance, then if we fabricate the custom appliance to those apnea guard functional settings, then we should expect that the custom appliance and the apnea guard should get equivalent results. So in this study, we randomly assigned patients to either the Herbst or the Micro 2. We articulated the custom appliance to the apnea guard VDO at 70% target protrusion. But by protruding them to 70%, when they would just be novice, having only worn the apnea guard once previously, we wanted to exclude those patients where there was radiographic evidence of degenerative joint disease or a history of TMJ dysfunction. Those patients were excluded from the study, and they were typically delivered their custom appliance at 60% protrusion. And here's what we can see. This is the overall AHI from study 2 that were 84 patients, and you see the significant differences between the custom appliance and the apnea guard. But now in study 3, it has about half the number of patients. We see that the differences between the custom appliance and the apnea guard are no longer significantly different. They're about equivalent. And this is despite the fact that the patients, the overall severity in the study 3 patients to date is more severe than those that were in study 2. Now there were two groups that we had sufficient data on to give you an understanding of how this might be working, especially in those that had increased vertical dimension of occlusion. So these are the men with the scallop tongues, and we can see again study 2 and study 3 for the overall AHI, and we see the trend where the custom appliance and the overall AHI was greater than what was with the apnea guard in study 2, and now the results in study 3 are equivalent, and again, despite the increased severity. And when we look at the non-supine AHI, again, we see the same pattern emerging, where articulating the custom appliance to the apnea guard settings is giving us superior outcomes. We also looked at the data in women with scallop tongues, and this is a group that if you read our paper, we suspected that women with scallop tongues may have been outliers or a phenotype that didn't treat out as well with the custom appliance. These data are suggesting otherwise, in that maybe now the reason that they didn't treat out as well with the apnea guard may have been that when you added the vertical dimension and combined it with the bulkiness of the apnea guard in these females, that may have lost some of the effectiveness of the apnea guard functional settings. But when you transfer those settings to the custom appliance, we're now seeing that these females with scallop tongues are treating out quite well. So here again, the overall AHI, this is from study 2. Now we see in study 3 that their results are equivalent, and also in the non-supine position. So we find this quite promising and look forward to presenting the results sometime next year. So in conclusion, in order to optimize your oral appliance therapy outcomes based on the data that we presented today, plus the 15 years of research that we've been doing on this topic, we make the following suggestions. First, about VDO. We recommend that women are fitted with 5 millimeters of VDO and possibly more based on tongue scallop. For men, we recommend that they're fitted with 6.5 millimeters of VDO and then increased based on tongue scallop. We strongly suggest that we control vertical mouth opening, that is going to have an impact on the supine AHIs. And that either men or those men or women with scalloped tongues, it's more likely that they are going to be labeled a non-responder when you use the endpoint AHI less than 10 due to the likelihood of them having elevated non-supine AHI values. We also strongly recommend that you encourage your patients to avoid supine sleep. This is going to improve your oral appliance therapy outcomes and potentially reduce the risk of neurodegenerative disease. We also strongly recommend that you look and evaluate residual POSA after you've treated the patients with your custom appliance. If you're using oximetry, you should really add position to it so you can identify those that have residual POSA. It will help you convert those patients who might appear to be non-responders with oral appliance therapy and convert them to responders. And finally, treat the patients with a non-supine AHI less than 5 with supine avoidance. It will save healthcare dollars and result in superior outcomes. And finally, we wish to thank our research collaborators, Sleep Alliance, Sleep Data, and Better Night Sleep. And for more information, you can go to our website, advancedbrainmonitoring.com.